Like, see, yesterday I was actually doing
Okay.
questions.
Yeah,
You
we
just text me.
Okay.
I can just come in on a random day if you have time free. I'm able to come in and questions. So I don't have to prepare for it.
Yeah.
Right. I just work with you.
It's a book.
Correct. So I can just work with you for the questions.
That would be really easy.
That would be nice.
Yeah. So I mean, I don't care about that as long as I have the time and I don't have clinic in the morning that runs over. And I don't,
Yeah,
because
the
I don't
questions
need
are
to
all
prep
done.
for
You
that.
just have to go through it. And
Yeah.
for instance,
Okay, so then maybe what I'll do is I'll stick with this today. Tomorrow I have EMGs in the morning, and if nobody else is showing up for lecture, you want to do questions, I'm still able to come up.
Where it's he's reminded, but if he's not here, I'll text you.
You can just text me. I can finish EMGs, come up here and do questions. Okay.
that's noon or morning?
Noon. Morning,
Morning is
morning. No,
lovely.
I have my patient calls scheduled in the morning. So when you talk about treating patients with MS, you have 3 different approaches. I always tell them there's 3 different approaches. One is, of course, you would want to use disease-modifying treatment, and that's a whole different aspect of treatment where you want to monitor their clinical relapse status, their MRIs, and their disability progression. That's one aspect of managing MS. The other aspect is symptom management, because despite EMDs, the symptoms are separate from that. And the third aspect is lifestyle modification. Maybe weight loss, vitamins, other supplements. You have so much data now on folic acid, be it biotin use, be it antihistamine use, all the other aspects where there's data and, where I talk to patients about that aspect. So today's talk is going to be essentially symptom management in MS because they have a lot of symptoms. Can you think of some of the symptoms? Optic neuritis can present with pain. Right? Yeah, it's one of the pain.
Incontinence.
Yeah, incontinence, so bowel, depression, bladder,
Ambulatory dysfunction.
walking, correct, gait, depression, sex, so mood. What else?
Paresthesias, is that pain or is that
Sure, sensory.
dementia?
Cognitive, absolutely. Couple other key things.
Autonomic dysfunctions and
Bowel bladder, sexual dysfunction comes under the same. Fatigue and sleep are 2 other aspects that they have a lot of problem with. Fatigue is a big issue. Okay, so these are some of the key symptoms that patients with MS have, and irrespective of what disease-modifying treatment you use, you would still need to treat each of these individually and tackle it because these are big things that come in the way of their everyday life functioning. And a lot of the time I spend with the patients dealing with these individual symptoms. Hello? Hey, yes. It is. Right. Okay. Okay. Like a peroneal. Yeah. Okay. Sounds good. All right. Thank you. Thanks so much. EMG. What's the verdict? Yeah.
Peroneal?
Yeah. It goes with the clinical, right? So that's good. The foot drop patient. Yeah. So you need to know this for today. So eliminate, reduce symptoms that impair functional abilities, improve their quality of life, and avoid secondary complications. And it's individualized treatment. So we've talked about all of these. Spasticity, we can put that in dizziness. So I put spasticity under pain. I'll be talking about to dizziness, tremors. Tremors is a big thing. So I have to put it in my slides, but it's here. Pain, itching, not as common, but I do see an occasional patient with itching. And vertigo and some other non-specific symptoms. What's that? Itching? They can have dermatomal irritation. So itching tends to be typically like a neuropathic pain type of a thing, they can have itching. It's not very common. It's less than 1% of patients who present with it. And but I've had a couple of patients who present with it. So essentially, you want to add to different aspects of symptom management. It's not just prescription medication. It's going to be part of it. It's going to be patient education, referral to specialists, and physical activities do play a big role in mitigation of a lot of these symptoms. Where these symptoms can come from, sensory symptoms come from the dorsal column, optic neuritis, diplopia, vertigo, etc. from the brainstem. Bladder dysfunction can come from the brainstem. Tremor, ataxia from the cerebellum, Lhermitte's pain, proprioception, sensory symptoms all from the dorsal column. Cognitive loss, essentially because there's a lot of gray matter involvement, as we've come to understand more recently, as well as volume loss, atrophy. And then mood disturbances from the frontal lobe. So these are some of the symptoms that we'll discuss today. The first symptom is fatigue. So fatigue is often a very, very common symptom in patients with MS. So when I talk to them about fatigue, you want to try and first of all understand, where this fatigue comes from. So often there is an underlying secondary cause, and often these are due to the medications that we use for these patients. So a lot of these patients are on anti-epileptic medications. They're on muscle relaxants. Muscle relaxants can cause a lot of fatigue, baclofen, tizanidine, or Valium. Any of these, they can cause fatigue. They can be on mood stabilizers, which can also cause fatigue. So patients are so fatigued, like for instance, they're on mirtazapine for mood. That can cause a lot of sedation, daytime drowsiness, even if you're taking it just at night. So trying to identify. It depends on which one you're using. So the older generation ones, like the interferons, can cause what is the main side effect of interferons? Flu-like symptoms. And flu-like symptoms include body ache and fatigue. So the earlier disease-modifying treatments, yes, they do cause a lot of fatigue as a part of the side effects. Copaxone, not as much. With the oral medications, you don't see it as much. And with infusions, neither. Okay, with the earlier medications, you do see. So anticonvulsants, antihistamines sometimes are used, and muscle relaxants, etc. They can have comorbid medical conditions, which you always look for. A lot of our patients have obesity. They have underlying sleep apnea, which goes unidentified, which can again present as daytime fatigue. They have mood issues, so they're depressed because either primarily from the MS itself, or secondly because they have MS, they're depressed from that. They're not able to do their everyday activities, they're depressed from that. So that often is a cause of fatigue. They might have poor sleep because of sleep issues that are underlying, insomnia, etc., B12 deficiency, infections, things like that. So this is stress, anxiety, depression, and then sleep disorder. They can have sleep issues because they have like a bladder urgency and they have to keep going to the bathroom all night and they don't get enough sleep. They can have sleep issues because of restless leg that can be coexistent, spasticity that wakes them up, pain, and sleep apnea we talked about. So when somebody talks to me about fatigue, I try and address the first and foremost thing that I do is look through their med list to see if there's anything on there that's potentially contributing to the fatigue. And then if there is, try and modify the dose. Like we were talking for, I think one of the patients on the consult service, somebody who was on 2 different agents that was contributing to daytime for the altered mental status patients. The patient was on dantrolene, which is heavily sedating, as well as the patient was on mirtazapine, which is also heavily sedating. So I thought that was contributory. So you'd want to look at those lists, take it off. High index of suspicion for sleep apnea, send them for a sleep study, treat their insomnia, so that their daytime fatigue gets better. Now, despite all that, sometimes fatigue persists. We talked about this. So some non-pharmacological measures is during the summertime, stay cool, drink cool liquids, exercise. Exercise does seem to help. And to mitigate fatigue, again, there are different strategies that we can employ to help patients. So short bursts of activity, patients seem to do well than trying to do subnormal sustained level of activity. So we try to tell them to do short bursts of activity, get a break, and then get back again to high intensity short bursts than to do low intensity prolonged. That seems to help patients. And then there are some pharmacological management measures that we use. So we could use amantadine. So all of these pharmacological measures, not FDA approved, They are off-label treatments. There are some studies that are done. Some studies say they work, some studies say they don't work, which happens in real life too. So some of my patients say yes, they benefit from it, some of them don't. So we do use the amantadine, which does have some NMDA type of activity, right? So it's originally used for influenza, then subsequently for Parkinson's treatment, and now we use it for alert as an alerting medication. Provigil, amphetamines. Do you know what 4-aminopyridine is? Gait, walking, correct. So it's the same as Ampyra, right? That does have some alerting activity. SSRIs, Wellbutrin, and some other SSRIs, SNRIs. So we can use a combination of these medications. A lot of my patients do end up being on this bottom half of the list anyway, because depression is a big comorbidity that's seen in MS patients. So I could try and use them both together. You're treating depression, which can contribute to fatigue, as well as try and treat their fatigue. Okay. This top half of medications, I try between these two. I don't prescribe the amphetamines. I'm not comfortable prescribing it, so that's why I don't use it. But there are some others who feel comfortable and they use it. I use between amantadine, Provigil, and then SSRIs and SNRIs to help with the pharmacological treatment of the fatigue. Now, what is one? What's that?
You started with this
100 milligrams. Yeah, I use it. So here it says BID to TID. What is one key side effect do you think that could come from these medications? Insomnia. So you would not want to use it in the later half of the day. So I always tell them the first dose in the morning. So some people feel like they have good energy in the morning, and only in the afternoon they feel like they're fatigued. So the second dose at the latest, I tell them not after 1 or 2 p.m. in the afternoon, because after that you don't want it to interfere into their sleep. So I use amantadine at 100 milligrams in the morning and 100 milligrams in the afternoon. I sometimes do even 200 in the morning, depending on, it's very individualized depending on how they feel. It's symptomatic, right? So if they say 100 doesn't work for them, I try the 200. If that doesn't work, then I say, okay, we'll stop it. We'll try something else. And then we could move on to Provigil. Provigil also similar dosing. I use 1 in the morning, 1 in the afternoon. This is a standard dose. The Ampyra, the Dalfampiridine is 1 in the morning and 1 at night. The SSRIs, again, we tend to use it once a day. So it's experienced by 95% of the patients, 60% reported as being one of the most troubling symptoms. And we talked about some of the other techniques, spacing and energy conservation techniques, OT and PT. I haven't referred them to OT or PT for specifically fatigue management.
For fatigue management, when you're initially diagnosing someone with MS or telling them about their diagnosis, do you automatically put in a referral for psychotherapy or like some kind of behavioral counselor or something like that because of the adjustment disorder that most of you?
I don't automatically do it simply because we don't have enough people.
Yeah.
We don't get enough appointments. I try and manage as much as I can for myself, trying to identify the medical issues that they might have coexisting. And if I don't see that they have a big, if I don't see that mood or behavioral issue is a big part, then I even try and manage it myself, because it's very limited. If you see the access for them to go to psychiatry, is very, very limited.
I wasn't
So
sure if they would like
they could benefit from it. They could benefit from it if I have the access to it in the real world. But yeah, it would be a good option if they could have access to it. So the next thing is cognitive impairment. So each of these symptoms, they always have an overlap from the others. Like for instance, cognitive impairment, there are some aspects that are preserved in MS. There are some aspects that are not. Things that are preserved are procedural learning, general intelligence is preserved, attention, like they can read the eternal line, that's not a problem. And general information regarding facts, recognizing objects, things like that, vocabulary words are preserved. Things that affect them are processing speed. So they have difficulty going through multitasking. So that becomes a big problem for them. They have word finding difficulty. They are not able to, they have executive function difficulty, word finding difficulty, fluency of speech. And then episodic memory issues, and eventually encoding of memory. So common complaints often are, they have the tip of the tongue phenomenon, wrong word came out, blanking out in a familiar area, difficulty following directions, conversation, And that leads to personality changes and withdrawal from social activity because they become more and more dependent for their ADLs. So perseverative errors are common problems, and recent memory is dramatically affected. So studies show that in up to 50 to 70% of patients with MS, there is cognitive issues. Now, this could be a primary cognitive issue, but it can be an under-recognized problem relating to either, like we do for our dementia workup, right? You would want to look for if there is depression that is untreated, sleep apnea that's untreated, that's potentially contributing to the cognitive impairment, not getting enough sleep. Okay. Things like that. So some of the indicators are they are not able to provide a coherent history to you. So that would tell you there's something going on with your cognition, perhaps. Significant abnormality, especially if you see signs of atrophy, difficulty following directions. They don't keep up with their appointments. Missed clinic visits, phone calls, difficulty at work. They lost their job recently. And then, of course, the family members come in and tell you, this is not how they were functioning 2 years ago. So you can identify it by all of these clinical cues. At the bedside, I often use a MOCA to help me put down a number, but the MOCA is not often very helpful for you to understand all of these other aspects, the word finding issues, things like that, right? So you can send them for neuropsych testing, which actually is there's a whole standardized battery of tests that are available. There are some other battery of tests that you can do at the bedside, but for that, I would have to spend like plenty hours to do with the patient, which practically is not possible. But if insurance pays, neuropsych testing is the gold standard, and you are able to get disability evaluation, vocational assessment, things like that. This is the whole different battery of tests that can be done to understand what's happening in terms of the cognitive impairment. But to tell you the truth, again, maybe 5% of my patients have undergone formal neuropsych testing because of the payment, because it is an expensive test, and our patient population insurance does not often pay for it. So often I go through, again, trying to figure out what's reversible and treat that, because that's an important part. Also trying to find strategies to help these patients, be it trying to talk to the primary care doctor to see that there's an aide who comes in to help them, or for that matter, trying to talk to the family members to help them with their medications, calendar appointments, one task at a time, alarm systems, kitchen timers, different things that I speak to them in the clinic, and then refer them to the occupational therapist who can go through their everyday. So MOS has, they go through their everyday. Either they go home and they assess what they do every day at home and see where they have the functional difficulties and deal with them, teach them how to deal with it at home, or they have them come into MOS and go through their everyday activity, get them to turn on the stub, see how they do there. Do they have difficulty with doing it? Do they know how to do it? Things like that. Importance of treating is obviously because it contributes to them losing their job, accidents, things like that. What about treatment? There isn't really much in the way of treatment. A lot of it is behavioral compensation. So be it processing speed, working memory, so it's speech therapy, occupational therapy, and general cognitive rehab. Cognitive rehab is a big bracket. Again, insurance does not tend to pay for it. So I send them to OT, which is an indirect way to do it. And OT, if I put in the diagnosis of memory loss, it doesn't get paid for, so I have to put in multiple sclerosis and something else, and then I talk to the occupational therapist directly to get them to work with their memory issues. But speech therapy, occupational therapy, cognitive rehab seems to be like a big part of this. There are some computer training methods which are used, but I don't know if our OT does it for my MS patients. And then you can try and use these, again, alerting medications to help mitigate their fatigue and help them focus on their activity. I use, again, the amantadine, Provigil, and Nuvigil. I haven't used the amphetamine. There is some data to say that Aricept plays a role. I use it if it's an older patient, because Aricept also has its own set of side effects in terms of bradycardia, GI issues, sleep issues, things like that. So I haven't seen much of a benefit with that. So overall, cognition is a big problem, and we don't have a great solution, like how we struggle with managing dementia and otherwise. It's a lot of it is strategizing and trying to help the patient go through their everyday activities. Then stay active, reminders, appointment reminders, planning, organizing. We spoke about that. The biggest thing is, of course, it says exercise the mind here. I just pulled this from the CMSC meeting. Although that is there, I think physical exercise does play a much bigger role than exercising the mind. Okay? So there is now more and more data to say exercise does help with mitigation of fatigue, though it might seem counterintuitive that they're not able to exercise. Exercise does seem to help bring up some good endorphins, hormones, and helps mitigate fatigue and so also cognition. Then moving on to gait, there could be different types of impairments that limit ambulation. One, first of all, weakness itself. You do the manual motor testing, they're weak because they've got a lesion in the brain and the motor tract. So that could be a problem. Spasticity. So you could do the physiatrists often do the modified Ashworth scale for spasticity testing, and that's a big problem with the gait. Sensation, localization, proprioception is a problem. Balance, because the visual system, the vestibular ocular system is affected, and strength is affected. Then, of course, coordination, because the cerebellar system is affected. Dyspnea, dysdiacokinesia, intense tremor. There are a lot of different aspects that are affected that can contribute to the gait impairment. There are different ways to measure gait in the clinical setting. The most commonly used, what I use every visit, is if they're able to walk, is something known as a timed 25-foot walk. So I have a measurement in both my clinics where they can walk. So you get them to start, and they can use whatever device they're using for me to time it, because that's what they use in the regular, outside of here too. So you get them to walk the 25 feet and get them to walk back the 25 feet, take the average of the 2 times, and that'll be their time 25-foot walk measure. That's the easiest for me. I do it either at the beginning of the clinic or at the end of the clinic, so I can time it and document it. And for me, I can see a trend. Is it getting better? Is it getting worse? And that helps me understand what's happening with their gait. That's just one aspect of it.
There's like a pretty large difference between going there and back. Does that indicate anything, or is it just
Probably fatigue, because the first time, so typically what happens is they go faster the first time and then they're slower by the time they get back. In that case, it's probably fatigue is what I would attribute to. If they're not doing it right, I'll get them a period of rest and do it again. Yeah, which is why you want to use the average of the 2 to help. The other measures that are often used, I don't use it, but that is used is something known as the timed up and go. So that is, you get this patient to sit, you tell them when you say go, they stand up. You use it for NPH patients, right? So when you say the word go, they stand up, they walk the 10 feet distance, they come back, and that's what you would measure. And they sit down, and you can do 2 trials to help for the timed up and go. That's also a fairly easy method to check in clinic. Then you have something known as the dynamic gait index, which I haven't used at all, but it's used in the research. Basically, they get up, they walk with their head turned to one side, head turned to the other side, head turned down, and then they walk back. So there's also some other things where you can stop and walk over an object. So it's very dynamic. So I don't know if they use it in the gait lab. Our gait lab at Moss is automated. A lot of it is automated. They video it and they see where their problem lies in the gait in terms of their stance, the cadence, the speed, and all of that. And then they monitor that and then make recommendations based on what they see in the gait lab. I don't know if they use this measure. A couple of other measures that we use are something known as the 2-minute walking test, basically along a 60-foot walkway at a comfortable pace back and forth. And the 6-minute is the same thing for a 60-foot walkway back and forth. I only put this here because in case they ask you questions, you have to be familiar with these terms. So this is the dynamic timed up and go, dynamic gait index, 2 feet walk, 2-minute walk, 6-minute walk, and the timed 25-foot walk. Then in terms of how we approach these patients, it's typically a multidisciplinary approach. There's only so much that I can offer for them. So I do use the physical therapist a lot, the motor control lab, the orthotist for orthotic devices, and then the physiatrist, and of course spasticity management. So it's again multidimensional. You don't want to treat the spasticity so much that they're weak, that they're not able to walk, and often that can happen, especially if you're using Botox or phenol injections. You don't want to overtreat the spasticity because you need that tone in the limb to help them walk, but you don't want it to be so stiff that it doesn't move. So it's often trying to find the right balance to help. So the role of the physical therapist is in helping strengthening the core muscles as well as the limb muscles, and some task-specific training. The Ampyra or Dalfampiridine was approved, I think, about 7 years ago. That's a medication. Maybe I'll talk about it in a bit. So, and then spasticity management. I'm not going to be talking about that also in a bit. The orthotics that aid are things that you're familiar with. You have the ankle foot orthosis that can be used, and there's something known as the Victus band that can be used. There's different types of hip flexion assist devices that can be used again. And this is something known as a Bioness or a walk aid. I haven't seen any of my patients use this, but I'm pretty sure Moss does have a lot of this walking assistance devices that they use. So balance problems can come from sensory issues. So the physical therapist and the occupational therapist work with my patients to try and give training to them to help with the balance issues. There isn't a specific medication that can help, but they do vestibular ocular reflex training, like they do for vestibular therapy for other patients. They do a lot of that training with the repeated stimuli to help them understand their sense of balance. And then, of course, using the mobility devices, different mobility devices, canes, crutches, walkers, rollators, scooters, wheelchairs. So dalfampiridine or Ampyra is foraminopyridine. It's a potassium channel antagonist. The way it's supposed to work is that in regions where there is demyelination, there's excessive activity of the potassium channels, and hence there is, so potassium works in repolarization, right? It does not work to help depolarize, does not help activate the muscle. So these go and block those potassium channels so that they don't work. So I should put up a picture. Basically, in the region of segment of the demyelination, there is not much of the sodium channels, but there's more of the potassium channels. And these go and block it, and that helps basically enhance the signal across this nerve. The dose is 10 milligrams twice a day. Key side effects of this medication: one is it is metabolized by the kidney. So if their GFR is under 50, you are not allowed to prescribe it to them. Secondly, if there is any history of seizures, you cannot prescribe it to them. It does increase the threshold for, decrease the threshold for seizures. They can be at a higher risk for seizures because it acts in process. So I don't use the recommendation, not just me. The recommendation is that you do not prescribe it in anybody who has any history of seizures and kidney dysfunction. The also the other thing is it does not. The study showed that when it compared to placebo, in patients who used this, only 40% of the people who took this had a 25% improvement in their walking speed. So it's not that much more compared to placebo, where they had 10% improvement. So the data is not big, but it's one medication that's there. And we do know that it seems to help with fatigue. It's being looked at for memory loss for the same reasons, because it increases conduction through these demyelinated pathways. So they're looking at it for other aspects of MS. So this does not, so if you can see that it's not miraculously just working on the legs, it's basically working on any demyelinated fiber, right? So if I see a benefit in their gait, I still keep it on for them to help with the other functions. But the effect is at best modest. Then pain is a big part of managing MS patients. It's anywhere between 30 to 80%, more than 50% find to be a significant problem, and interferes with their work, sleep, and life in general, right? So they can have different types of pain. So pain can be neuropathic, where that could be central neuropathic pain or peripheral neuropathic pain. So they can have pins and needles, a classic neuropathic pain description. And the type of medications that we use are like we use for any other neuropathic pain, anti-epileptic agents such as Neurontin or gabapentin or pregabalin. We can also use tricyclic antidepressants, SSRIs to help with the pain, carbamazepine, Tramadol, things like that. Then extremity pain. This is a little bit different, similar to your restless leg, but they tend to have a lot of bilateral feet pain, worse at night, exacerbated by exercise, and burning type of pain. Again, These the patients are we think that these come from the cervical and thoracic spinal cord and often managed by the similar type of medication. So it's more for descriptive purposes that these different types of pains are described. The management essentially is the same group of agents, antiepileptic agents and antidepressant medications. Trigeminal neuralgia, the incidence of trigeminal neuralgia in multiple sclerosis is about 20 times more than in the general population. So like you were talking to me yesterday, which are the patients that have clinically isolated syndrome? How do you not call somebody with fatigue as a clinical isolated syndrome? Trigeminal neuralgia is one of the telltale signs. So if it's a young patient with trigeminal neuralgia coming in for the first time, I have to look at the image, not just for the vascular loop, but for demyelinating disease. Okay?
The one that we were discussing.
Yeah, because you can have these patients with a lot
I'm
of
really not
Do
sure.
you image anybody with something like suspicious? Or I guess you only call it a clinically isolated syndrome if there's no MRI lesion correlating. Sorry, no MRI lesion.
So what's a clinically isolated syndrome? Sorry, we're breaking away from this, but you need to know the basics. So some classic telltale signs of MS. What are some? Optic neuritis, transmyelitis, what else? Trigeminal neuralgia, in young people. INO, right? Yeah. So these are some of the really classic ones that they can present with. But they
So I
can
guess
present
we
with
were
many
wondering,
persons.
like if they were like, oh, this is tingling, or oh, that's numb, but it doesn't really.
So they
it's
can
not, like,
present with
typical.
the tingling. Okay, so if it's a hemi tingling or a hemi body phenomenon, which is occurring acutely, and so those are soft signs. Motor is a more hard signs. Sensory is soft because it's subjective. There's only so much that you can get from it. But when you examine the patient, so this is just what the patient's telling you, right?
Right.
So if it's any of these are pretty typical, or the Lhermittes, right? So that's very few things that can give you that kind of a pain that the patient describes to you. So bowel bladder, right? Again, in a young patient, bowel bladder shouldn't have bowel bladder issues. So if they have something like that, we should think about, oh, do they have something going on there? So these are the ones that present with clinically isolated syndrome. They may have lesions on the brain MRI may be normal, or the brain MRI may have lesions. Okay. Now if their brain MRI is normal, then and they've had an optic neuritis, or if they have one lesion, then the risk of developing MS. We discussed this. That's why I'm asking you.
70%.
No,
20%.
20%.
Oh, one. Oh, more than one.
lesion,
Is
one
80.
lesion or
More
not.
than one.
If they have anything more than one,
One.
it's 80%, right? So that's what it is. Over the next 10 years, INO, internuclear ophthalmology. Yeah, it's a lesion of the medial longitudinal fasciculus, which is again very classic for demyelinating disease. Okay. Again, see, it's not hard and fast limited to this. Somebody who has a cerebellar issue, a unilateral cerebellar issue, you want to think about MS. This upper class of things,
It's like middle.
it's somewhat middle. And then sensory is somewhat lower down.
So I think we
Fatigue
were
is lower
thinking
down.
about a clinically isolated syndrome that was something like fatigue or like a tingling numbness that was not really disruptive.
Yeah, so then it's hard to call it a clinically isolated syndrome, especially if the imaging is normal. Now, if the imaging is abnormal, you could take that and call it.
Okay.
Probably, if it goes with it, if you see objective signs, when you're examining the patient, you see there's an APD, you see that there's an AD saturation, you see some other telltale signs,
Okay.
then you take it. It's difficult. I think
to call anything.
that's why I said, you know what, I can actually do some questions with you
Okay.
so we can go over it because it's very difficult and you may not actually have a right answer. Even, yes, I change it. I mean, it could be a radiologically isolated syndrome and then I see something else on exam and say, okay, maybe this. So it's very dynamic and it's very from patient to patient.
Did you image anyone that has bilateral trigeminal neuralgia for MS, even if they're not like the young females or even
Almost everybody gets imaging. When bilateral is again pretty fancy. Bilateral INO, bilateral trigeminal neuralgia, you want to think about MS for sure. Yeah, we do image almost all of our trigeminal neuralgia patients for looking for the vascular loop, right? So that's a secondary. It's not an idiopathic cause. It's a secondary cause of trigeminal neuralgia. because then you can consider if they don't respond to medication, you can consider compression treatment for them. So similar to that, so these patients, they have the similar presentation, and treatment-wise, they can have, first line of treatment is ADs, like we do Tegretol, Trileptal, gabapentin, Lyrica. You could use all of those. Second line medications, often I use baclofen, that can help. You can use Depakote, you can use Tocomax, you can use Zonogran to help with trigeminal neuralgia pain. And if that doesn't work, then you could use radiofrequency rhizotomy or microvascular decompression, depending on the case.
In trigeminal neuralgia, it's mainly the nerve demyelination, but not the nucleus, right? Because I had a patient that there was a question that radiology requires a nucleus.
It should be the nerve that demyelinates.
Not the nucleus, right?
I'm not sure.
If it's a
of the
nucleus, would it
distinction.
be more than just Henderson?
First of all, the trigeminal nucleus extends along from the bones all the way down to the cervical collar, right? It's one of those long nuclei that's there. So I'm not sure. You'll have to bring that back to me and show me what they talk
Well,
about.
this is a case Liana had, and I saw it at Elkins Valley Deputy, where she sent her there for her ophthalmologist. So because Liana thought she had a demyelination because she was concerned about MS because of trigeminal neuralgia.
Yeah, so you could have a lesion in the pons, but you can have a lesion along the tract too. But yeah, and more often you see the lesion in the pons. I don't think you can track the nerve itself for demyelination. I don't think our MRI is sophisticated enough to look at that. But often what's an indirect clue is at the region of the nucleus, you will see areas of demyelination, and I put it together, and then you'll see other demyelinating lesions. Then, I missed something. Lhermitte's phenomenon, it's seen in about 15% of the patients. It's an annoying symptom when patients have it. Tends to occur during exacerbation associated with posterior column signs. So I've had a couple of patients who have the symptom, which is very bothersome because they can't bend their neck to even eat food, right? Because the moment they do that, they have that shooting pain. So it's an annoying symptom and sometimes refractory to treating, especially if they've been in the active phase of the disease. Eventually, it responds to treatment. Here it says symptomatic treatment is not necessary, but I've often used, again, similar line of medications, ADs or tricyclic antidepressants, fortunately. Then optic neuritis, presenting manifestation is 20% in 20% of MS patients, and about 8% have pain. This we treat with steroids in the acute phase to help with the pain. If they have long-standing pain, then you can again use one of the tricyclics or gabapentin pregabalin to help. Musculoskeletal pain, they can have associated because of the weakness, because of spasticity, reduced mobility, things like that. They can have pain, as well as compression fractures, things like that, and aging process. Management is again identifying the underlying issue. Often patients can have coexisting hip issues, knee issues, maybe obese, maybe getting older, which will need to be treated and not caused just from MS, so the ambulatory dysfunction, and not just from MS. Because if you treat them with a new hip, they might get better. Now, painful tonic spasms is something very classic, just seen with MS patients. They have this paroxysmal abrupt onset of posture of arm or leg, where they have tightness of these muscles, or sometimes of the back, occurs in more than 6 to 10. This is from one of the studies, but occurs in a lot of the patients, at least in half of my MS population. And lesions come from base ganglia and anywhere along the motor tract. So treatment-wise, you can use anti-epileptic agents. So typically I use Tegretol for treating these patients, or you can use muscle relaxants to help, baclofen or tizanidine or dantrolene, Valium, things like that. And then of course, Botox can be used if it's a recurrent muscle. So guiding principles in pain management, again, don't use opiates. Think about AEDs and antidepressants increasing the risk of suicidal thoughts, because these are the major class of medications that we use. Then topical medications, especially if it's the leg pain, things like that, I do use lidocaine sometimes, capsaicin sometimes. And there are some other MS neurologists that I've seen who use compounding pharmacies to help with pain. Cannabinoids have been approved for use for both pain related to spasticity and as well as spasticity. Right now, I don't have the prescription formulation here. Though it's been approved for use, we don't have a pharmacy that dispenses it, or we don't have a way to prescribe it. But Almost 100% of my patients want this, no matter what. And the
With or
data,
without MS, right?
without MS, and the data isn't strong. If you think about it, both the studies that looked at spasticity as well as pain, they did not use an objective scale. It was a very subjective scale. So it's without an objective measure. When the objective aspect was looked at it, the benefit was not as great as when they looked at the subjective. We still got approved because subjectively it seemed to make a big difference to patients. Probably. Well, these are not supposed to cause the result in the high that the THC does. Okay. So opiates I almost never use it, and it's not indicated. Non-pharmacological measures for pain management. Again, chronic pain results in kinesophobia, which means they don't want to move. That results in deconditioning and further worsening of your problem. So it is important to tell them that you need to break the cycle for rehab to take place, and then exercise. So that's I'm a big proponent of this for the patients. I always try and get them into rehab, so that it's easier said than done. Push them, which I understand. I mean, they have their own set of problems, which is I think a big barrier for them to get better, right? Other things that rehab does is stretching, massage, acupressure, puncture, cooling, etc. Then a couple more topics. Bowel, bladder, and sexual dysfunction. 60% of patients have bowel dysfunction. 80% have bladder dysfunction. About 50 to 75% have sexual dysfunction, and they can occur anytime in the disease course. Bowel dysfunction, commonly they can have constipation, involuntary bowel diarrhea, flatulence, fecal impaction, etc. Constipation, we are familiar with it, we know how to treat it. Use, movement. Again, it can't be sedentary. You want to keep moving, plenty of fluids, fiber, etc. And then, of course, you can use stool softeners. The more difficulty in treatment is somebody who has involuntary bowel movement. You can try and do bowel training, use a more bulky diet, suppositories to help empty it on time, and then medication-wise, you can use a couple of categories. You can use the loperamide, which is Imodium, and Lomotil, which is diphenolate. They have some anticholinergic properties, so they help prevent the movement. Some patients who are on opiates may have an indirect benefit of being on the opiate because it causes constipation. I don't use opiates, but I know some others do, and that could help them with the bowel movement. But overall, it's a struggle. When it comes to bowel movement, involuntary bowel movement, ultimately, if any of these medications don't work, they end up being in diapers. Then bladder issues, very common. They could be 3 different type of problems. One is inability to store, which means they gotta go, urgency, frequency. This is a much more common problem than difficulty going, which is hesitancy, retention. And sometimes it could be a combination where there's a detrusor and sphincter dyssynergia. That's probably the most difficult to treat because you can't use a medication to go and you can't use a medication to hold, right? In which case I refer them to urologist. Thank goodness for urologists. So there's a lot of problems that occur, and it leads to daily life consequences. Like, I can't go because I don't like the inconvenience of, I don't want to take a long car drive because I don't like the inconvenience of having to go. I don't want to wear diapers, things like that. And often a very, very common problem resulting in social isolation, loss of intimacy, tissue breakdown, etc. So things that you can use. So the inability to store, or basically the patient has urgency, has to go. You can use some techniques, limit their fluid intake, especially towards the night, frequent time bathroom breaks. So if they feel that they go often, you can time themselves and go, quick access to the bathroom, of course, wear diapers, decrease use of bladder irritants, so less of caffeine, less of aspartame, which is present in the sodas, as well as your artificial sweeteners, correct. Sweeteners, so sweeteners have it. So caffeine, sweeteners, and alcohol. So try and avoid them. And then you can use pharmacological measures, which is a whole list of medications which have anticholinergic properties. So I often use oxybutynin for patients as my first line. I'm just familiar with it. I use it. But you can use trospium, you can use tolterodine, Tobias, Vesicare, Myrotrig. So there's a whole list of them that you can use. And if side effects limit one, then I can use the other. Typical dose for oxybutynin is 5 milligrams, and you can go up to 15 milligrams. There's also an extended release formulation that's available, so that way it's more convenient for them if they do need it. And so also with the others. The side effects, what's the limiting side effects with these medications? It's anticholinergic. That's a clue. Confusion. What else? What's something that can bother them a lot? Dry mouth. Yeah, that's the most limiting side effect that I've seen with these patients is they take it, they feel good with the bladder, but then they're constantly thirsty, mouth is dry, eyes are dry all the time, and then they can have some constipation associated with it too. So blurred vision, because again of the dry eyes, dry mouth, nose, throat, dizziness, drowsiness, confusion, constipation, rapid heartbeat, and drowsiness that can be associated with the anticholinergics, and cognitive issues secondary to use of the anticholinergics. Like it's the cause and effect. Then the other side of the bladder issues is the inability to empty the bladder. So it's a problem with the detrusor, or it's a problem with the sphincter, and post-white residues are more than 100. So this I don't typically treat. I refer them by the time it comes to, if it's this kind of problem, I often refer to urologists. There's a couple of class of medications and some strategies to help. One is making sure they drink plenty, as opposed to the other where you have to limit your fluid intake. Again, time dividing helps. Intermittent catheterization helps here because they can't empty it on their own. So they have to just learn to catheterize, and intermittent catheterization. Then you can use some antispasticity and alpha blocking agents like Prazosin or Flomax. And then of course baclofen, which is an antispasticity agent that can help. Tizanidine can help. I don't, when it comes to managing this, I send them to the urologist. I'm more comfortable treating the bladder that has urgency frequency. That's a more common problem too. This is not as common. And so also with the detrusor, sphincters, and dyssynergia, they need urodynamic studies to understand what's going on. Sometimes the urologist uses a combination of anticholinergics and antispastic medication with intermittent catheterization. Sometimes they use a bladder stimulator to help. So bladder stimulators are okay. Now, for me, always bladder stimulator initially when I treat patients is, what do I do about my MRIs? So bladder stimulators are okay. And so also our baclofen pumps, because they often my MS patients have.
Really? No, you can do that because we have one patient
I have one with a bladder stimulator.
Yeah.
You can do up to the neck. You can do up to the C-spine. You can do thoracic and lumbar spine, but you can do brain and C-spine.
Here.
Yeah.
Because they told us to take them to Jefferson, or sorry, Temple.
Yeah, I remember one lady here wouldn't do it because she didn't have bladder stimulator. But is that something that comes with the make of the bladder stimulator, or is this just generalized over because
So stimulators have not been around for that long, the bladder stimulators. And I have a couple of patients who get, again, it's only up to the C-spine. You cannot go below the neck.
a radiology who I'm not aware of this kind of fact. So they always ask for the
Yeah, they can only get head and neck, but they can get it. So yeah, either combination treatments or they get a bladder stimulator. And sexual dysfunction also fairly common in about half the patients who have MS. A lot of contributing factors: women with MS, decreased desire, vaginal dryness, loss of orgasm, anxiety about bowel and bladder function, UTIs, etc. And with men, they can have difficulty with erectile dysfunction as well as ejaculation. Oftentimes when it comes to this, I don't deal with it myself. Either I look at, one of the things that I look at is SSRIs. SSRIs can cause sexual dysfunction. So that's important to know. So if they are on it, and if I can change the class of medication for pain, then I will change it. Like for instance, we have a patient in common who I use it for, and her SSRIs made a big difference for her. So I took her off it, and she felt like the sexual dysfunction was much better. And she did better with, I just used a combination of Lyrica and some of the pain medications, and she felt better. So that's one thing that you as a neurologist want to look at before you send them to the urologist. Subsequently, then I send them for either behavioral therapy or the urologist who is able to prescribe. But unfortunately, the sildenafil is not, or Viagra is not covered by insurance. So they have to pay out. Mood, I forgot to create a slide. I'm sorry, I only realized it this morning. But mood is certainly a big issue with MS patients. They can have depression, they can have anxiety, they can have pseudobulbar effect, especially in the advanced phases. We have a patient here on the floor who does, I don't know if you have Anthony. Yeah, he had He had a lot of pseudobulbar affect.
He
He still has, yeah. So pseudobulbar affect occurs basically when you have loss of bilateral descending fibers, white matter. And so the bulbar aspect of it is that they have trouble with speech, they have trouble with swallowing, and pseudobulbar because it's not coming from the bulb, that's the medulla, but it's actually coming from above. And so they have a lot of emotional lability, emotional lability and incontinence. So inappropriate emotions. Correct, inappropriate emotions. Inappropriate emotion. So he was on Nudexta. So Nudexta is a medication which is a combination of dextromethorphan and quinidine. You know what dextromethorphan is? Cough suppressant. Correct.
It also has
So
an NMDA, right?
yeah, it does have some NMDA. What's that?
ALS patients.
ALS, yeah, again,
Same
so the
thing.
same thing. ALS patients have pseudobulbar effect too because they can have nodule involvement. So you can, so this is FDA approved. It's NEUDEXTA. It's an expensive medication, has not covered the insurance, and he was on Nudexta for a long time. It didn't really help him. You can use SSRIs, you can use SNRIs. Insurance often doesn't cover Nudexta, so you can use it. If that happens, then I use SSRIs, SNRIs.
Or is it?
No, there was no study to look at it, but I think it's off-label. Look at it. I think it's off-label. It's not easier to prescribe. It's easier to prescribe, and there are patients who are on it for other reasons. Right? Then for mood, of course, SSRIs, TCAs, psychiatry. So I think this is just a table of everything that we discussed in terms of symptom management. The whirlwind tour. But I'm happy to do questions with you because then you can consolidate.
Yeah.
Mhm.
Questions.
Yeah, and the question will help you remember certain things. Do you have any other questions for me?
But we also have a lot of like social issues, right? Like also a challenge where you cannot help much.
Social issues in terms of
Caretakers, insurance, MRIs,
That's a big-
that's a big.
yeah,
that's a
but
big
thankfully the MS Society has MS navigators who I used to have my own navigator. Now, yes, I used to have a social worker navigator until about 4 months ago.
Yeah, because at one time I had a really acute issue out there. Okay, trying to get a social worker.
No, not for the general clinic. I used to have only for MS. It was funded by the MS Society, but they withdrew funding. So I don't have one anymore. But they have one made available through the MS Society. So I can call and talk to them and they will get in touch with the patient and they will provide services.
My patient was not an MS patient, he had epilepsy. And his PCP was in Jefferson. He called me, he was like, "Can you help?" And it looked like he totally happy.
Check for the
I
AES and
called
see the
the
Epilepsy Society and check if they have. For MS, the society provides social worker. If I call and talk to them and give them the clinical situation and where the need is, they provide a navigator who can help navigate through this whole rigmarole of, say, the patient has cognitive issues, does not have anybody else they live with, needs OT assessment, PT assessment, needs a social worker to see. And needs to get, so the navigator actually is a big help, and the society provides that. Then the society also pays for imaging once a year to look for. So if a patient cannot pay out of pocket, there's a particular form that I can download and fill that up and send it to them. They'll approve it, and I can have the patient get imaging. If say they don't have insurance and they can't pay out of pocket, the society will pay for imaging.
Because you guys do MRIs like CT scans, right?
MRIs, not for these patients, but at least once every 6 months.
Most of them need frequent MRIs. I see that they like stuff. You get your ear to see some MRIs. Like some people we monitor very frequently. So.
At least once a year.
Yeah.
Some frequently, more frequently. If they're on TriSab, JC positive, high index, once every 3 months.
I also saw one lady. She was doing exercise and she was like, really happy with it. Like it was really helping her.
I think some of the medications come with the injectable medications, a lot of them, I think.
Yeah, the pharmaceutical companies always provide their own nurses. Hello, this is my training for the patients.
Nice, they come to your house.
Oh, okay.
Can I close this?
Sorry.
Oh, yeah,
I
let me,
think I like
cancel
this.
those.
Okay.
Yeah.
Yeah.
No, it's been okay.
I was remembering.
No, I-
I know, 2 times I forgot. So I'm like, no.